Good morning. Today is Tuesday, January 27th, and you are here for the Policy and Operations Committee. So see if we can get that right. I call this meeting to order. The first item on our agenda is public comment. And if you can limit your comments to no more than 30 seconds, 3 minutes, and state your name and address, please.
D. Jones, stay in the Orchard Department. Here to speak to you guys about 3D printing construction. You guys know I got this into the city's consolidated housing and community development plan. And here you see, I sent every single one of you guys the press release, but some of you guys here physically, I do have the press release from Gaudi Tech. This is the 3D printing company that actually has 3D printed 17 government buildings in Dubai, 400 plus projects all across the globe. As you see, I asked them that educate our local government, our county government, state officials, federal officials. The same 3D printing company is also going to be educating Congresswoman Scholten. I'm going to be having a virtual session with them because this guy is in California, in Los Angeles. So very excited to be able to truly be able to get 3D printing construction here across Kent County. Also excited because I'll be speaking to city government, but today also Congresswoman Scholten's congressional dialogue on creating affordable housing starts today, and I was invited specifically because of my advocacy for 3D printing construction. So I am going to bring the engineers here for 7 days. I wanted to be transparent as possible because I care about my public integrity and my care to the public and actually creating, truly affordable solutions and actually creating truly affordable housing and actually doing something about it and not just, because I know that politicians have the power and sometimes people feel like you guys aren't capable. And I know that I'm a community partner that can actually help the government. And sometimes you guys can't do everything by yourself as you guys are, fiduciaries and government officials. And I'm somebody that does have the resources. I'm somebody that does have the vision for this. And I'm very, very passionate about affordable housing and 3D printed housing because I know this is something that could benefit Kent County. So very, very thankful to be able to have Gaudi Tech because I speak to the company and the director of partnerships every day. Just educating and speaking to him, soaking up everything that he speaks to me about 3D printing, and just for them to be able to 3D print buildings, 17 government buildings in Dubai in partnership with the government in Dubai. My birthday is July 10th, but the King of Dubai's birthday is 5 days after mine, July 15th. And I've been to Dubai before. So I think this coexisting synergy is definitely going to be coming to fruition one day, as I've been out there for 4 days and as I was at an event. I was at a business event in Dubai, and one of the Rothschilds was actually in the room. Somebody stepped up to me and let me know that one of the Rothschilds was there. I ain't lying. And so I know it sounds unrealistic for a Haitian, French person to actually be in a room with somebody so elite, but I understand the financial global banking systems and who created the banking systems. And John D. Rockefeller's birthday is July 8th, 2 days before mine. So I think I'll really change this global economy one day.
Thank you, Dee. Appreciate that. I'm glad that all of our commissioners at Kent County are capable, unlike maybe our other politicians. So I appreciate that. Any other comments? Seeing no staff rushing to the podium, we will close that portion of our meeting. Next item on our agenda is approval of our minutes. Do we have a motion and support, please? Motion by LeGrand, supported by DeBoer. Any comments, questions, changes, or concerns? If not, all those in favor of approving last meeting's minutes, please say yes. Yes. All those opposed? Last meeting's minutes have been approved. Next item on our agenda, Dr. Cole, Medical Examiner Annual Report.
All right, I'm Steve Cole, medical examiner for this year anyway. And every year we share our performance goals and achievements and shortcomings, if there are any. So the woman picture there is Dr. DeYoung. I'll briefly, at the end of the presentation, mention why she's part of this deal now. She is the she is a deputy medical examiner. I guess I'd say she is the deputy medical examiner because other than me, there ain't no other medical examiners. Anyway, so she is helping as much as she can to cover the needs of the system, because I need, as usual, need a lot of help. Anyway, so our goals, to determine the cause and manner of death under the medical examiner law, that is deaths that have occurred that fall under the medical examiner jurisdiction, and these are basically all homicides, all suicides, all accidents, all bodies found without an obvious cause of death and who were not in a doctor's care at the time of their demise. And we do so by having, I think we're at 8 now, investigators who will take the calls from whoever is in charge of the body, and this can be usually hospitals or police agencies. And so our investigators will take the call. Oftentimes, they will go to the scenes and investigate what's there. Sometimes there isn't a scene if the person has died in the hospital. But anyway, they will gather information about how the death occurred. They will present it to me, or if Dr. DeYoung is covering, to her, and we will make a decision about whether an autopsy needs to be done. And so we have some metrics that we try to follow in terms of turnaround time is mainly it. So, I would say turnaround time as far as responding to the scene and as far as producing investigative reports. Our basic goals are to publish 95% of our reports that are produced by the investigators within 2 months. And if there are questions about why does it take that long or longer, I can address those, but I'll try to give the basics to start with. Then another goal, which is not going to be achieved for some time, is to publish 95% of our autopsy reports within 3 months of doing the autopsy. And I will address that briefly. Our total caseload, I should say, is really broken down into 2 parts. So the biggest part, and in 2024, it was 1,474 cases that we accepted as medical examiner cases. That is, our investigators reviewed the information, determined that they did fit within our jurisdiction. However, we had another sizable group, 371 of cases, which we term declined cases, and these are deaths reported by hospitals sometimes. Oh, thanks. By hospitals, or by, a lot of them by hospice. Oh, okay, perfect. Yeah. Okay. We all need a little assistance now and then. Anyway, so these are, the latter are a group of cases, it's a huge annoyance actually, representing the fact that whoever was caring for the person, either a hospice nurse or maybe just a doctor or nurse in a hospital, that they don't understand that these deaths do not need to be reported. They do report them, so we have to take the information down, sift through them, and then arrange for somebody, usually the attending doctor, to sign the death certificate, if they'll do it. Sometimes they refuse. So one of the things that we've tried to do recently is to provide some education to medical facilities about which cases do they really need to call us about and which ones should they not be calling. Let's see here. I'll try to keep up with what's on the screen there. So let's see, we've talked about, we've talked about our goal, which is to provide a prompt response to the scene investigations. That is, when we're called to respond either by phone or in person as promptly as possible. About, of the accepted cases, the 1474, a little less than 20% result in a scene investigation. Either because they're the ones we don't go to or because the person died in the hospital, so there isn't a scene, Others may be cases in which it's a low acuity. In other words, it's an elderly person known to be ill. They weren't in a doctor's care, so when they died, the death was reported. But it's really not necessary to send somebody out, especially in weather like this, and we have to pay them more if they go to the scene. So if they feel they can handle it, and I feel they can handle it on the telephone, then that's what we do. And let's see here. Okay, yes. Of the scene investigations that we did perform, just about 100% of our investigators responded to the call within an hour of being notified. Okay, just a little bit about race and ethnicity. I think that though I don't have the Kent County demographic data for all the inhabitants of our county, I think our cases pretty much reflect the racial and ethnic breakdown of what's in the county. The biggest groups in the middle category there, cases by age, 45 to 64 and older than 65, of course, constitute the vast majority of our cases. That's partly and mainly because it's the elderly that are likely to fall and break a leg at the nursing home or crack their head. And so it's a trauma death, it's an accidental death, has to be reported. But, and so they constitute a very large group of our reported cases. They very seldom get an autopsy unless there's some concern raised by law enforcement or by the family or by the medical people. And of course, not surprisingly, cases by gender, about 62% are males. Frequently, their last words were either "hold my beer" or "watch this." All right, causes of death. Let's look at the manner. We only have a few more slides here. Manner of death is natural. We have 5 manners: natural, accident, suicide, homicide, or indeterminable. By law, the medical examiner has to make a determination as to which manner it was. The main reason for this is statistics. And for the, I guess they still keep statistics at the Centers for Disease Control. I'm not sure what they do anymore these days, but at least some folks are interested in the breakdown of deaths. So natural, of course, is most common. Accident, mainly elderly people falling and breaking their pelvis or legs or hitting their heads. That's the bulk of the accidents, though not all. Then suicides and homicides constitute much smaller categories. And indeterminate are those cases where, you just can't tell. We fairly recently had a case of someone, I think it was a kid, who shot himself in the head. Well, you think, well, that's a suicide, assuming he was the one that did, in fact, pull the trigger. And to the best of our knowledge, that was the case. However, there was a lot of ancillary information that he was not suicidal, that he was it was a new gun to him. He was sort of fooling around, showing off to his friends, and ended up shooting himself. Well, in that case, unless somebody fesses up that they did it, or a reliable person says, oh, yeah, he said he broke up with his girlfriend and shot himself, something like that. In the absence of that particular case that I've described was ruled indeterminate, and we did not get any better information. The vast majority of times when somebody does shoot themselves, of course, it is a suicide, even though it may be masked on occasion as trying to look like an accident. Anyway, the causes of death, we have, I guess you all have your own monitor. If not, I can just point out that, again, overall, natural diseases account for the largest group of deaths. So natural disease, mainly cardiovascular disease. And then after that, it drops down precipitously to more traumatic causes, of which falls are the single biggest contribution to that. All right. right. So, causes of death by manner, this is the child death review, yeah. We have a state-mandated child death review system which consists of the medical examiner, at least the major police agencies in the county, and Child Protective Services and representatives from the hospitals. And what this group does is reviews the death of pretty much all children from birth up to 17 years of age, and they really don't have any power to change things. It's just really to get information for folks who study these kinds of things. In other words, there's no judicial teeth that this group has, but the cases are hashed out, and sometimes we meet as a group virtually, and sometimes, law enforcement will have gathered additional information that we didn't know from the medical examiner standpoint. So basically, sharing information can help, and giving guidance to law enforcement and to the Child Protective Services folks about the death, and maybe other children in that family should be evaluated. It has its uses, and it's mainly in that regard. To summarize all these complicated categories, if we break down the cases that we review in the youngest age group, which is like younger than 1 year, and then you look at the other end, kids 14 to 17, in terms of cause of death, by far the most common cause of death in the infants is co-sleeping, or unsafe sleeping. So the child is sleeping with the parent inadvertently rolls on them, or a blanket gets over the child's face and they can't breathe. So it is basically an asphyxial death. The older kids die the way adults do. They get shot or they get killed in an accident for the most part. So, and then there's, of course, a variety of other cases. And again, if there are any questions about this or any other of our activities, don't be shy. So we've done, on this specific goal of publishing our reports within 2 months of accepting the case, we're at 100%, so we're doing well there. This is a problem. The goal of completing autopsy reports within 3 months of accepting the case. That isn't an unrealistic, or I won't say it's unrealistic. It's not a bad goal. It makes sense. This kind of segues into the last few minutes of comments that I have, which is that we've undergone cataclysmic and catastrophic changes in our system in the last year. And I'm not going to go into all the boring details, but basically the group of pathologists for which I and my former deputy, Dr. Start, for which we worked, decided they wanted to get out of the autopsy business, and they cut us loose. And to make a long story a little shorter, we searched around for who was going to hire us to do cases. And we ended up with Michigan State. The thing is, about the time we were supposed to start for Michigan State, Dr. Start retired. So we have our practice that really is about a 2.5 person practice with doing the autopsies and all the administrative stuff, such as this, and I'm it. So Michigan State is trying to help. There just aren't very many forensic pathologists around, so we're trying to struggle through. I have a contract that I signed once I began with Michigan State that will end at the end of September, and I'm not a spring chicken. So I'm probably going to step down, and if they want to hire me back part-time, which is all I want to do, that's what we'll do. But the county's going to need a new medical examiner, and hopefully Michigan State will find enough people to do the work. So there's that. And drugs. I kind of added the end in the middle, I guess. But the bottom line is the most common group of drugs is opioids. So these are narcotic drugs that are used to treat pain. And people, of course, like to abuse them. And fentanyl has a has been for the last several years, was by far the biggest, 86% of our opioid deaths, and opioids constitute the single biggest group of all the deaths. Number 2 is cocaine, which is a stimulant, not an opioid, and then it kind of gets down to just individual or a few cases beyond that. So fentanyl and cocaine are still the biggest problems in our drug use community. Of course, it's mostly males that abuse the drugs, and mostly young people. So we have accomplished a few things. One is just basic survival, but we have been accredited for the past 5 or 6 years at least by the, I think maybe longer, by the National Association of Medical Examiners. So they have a program that kind of looks at whether you're doing things properly and so on. We have maintained our accreditation and just got accredited for 2026. Another problem that we have administratively, we get quite a number of unclaimed bodies. Either we can't find a next of kin, or the next of kin wants nothing to do with that person. So we can go through a process of having the state pay a small amount of money, and luckily there are some willing funeral homes here in Kent County that will arrange for the burial of these unclaimed people. I think we're second in the state in gift of life donations. Again, that's something I can explain in more detail if anybody needs to know. I think the number 1 is Wayne County, but then they're about 2.5 times bigger than Kent. And so, but they do provide, in raw numbers, a few more referrals. I think we have the highest incidence percentage of referrals. We do generate a little money through fees. And again, the next one is the takeover of the system by Michigan State. And then hopefully that will get better toward the end of the year. We also have made some efforts with hospice. One of our investigators, Tom Woderick, has given some talks to hospice organizations about which cases to report and which ones not to report to us. And we're trying to deal with this overload of unnecessarily reported cases. I think, well, okay, that's almost it. Future goals, we're hoping to get a new morgue. That is still very much in process. And I don't think we own a building yet, but there's one we have our eye on that I say we, the county in general, that we're negotiating with the owners out. It's out by U of M West / Metro. We'd like to increase our staff. We've had some trouble administratively where we've had several clerk typists quit, and poor Brittany has been trying to keep her head above water. Now we have a pretty good one who we hope is going to last, and so that's been one problem. And we would like to make her, this clerk typist, Brittany's assistant, we would like to, we're going to aim to get her full-time if possible. And we're just trying to keep our staff together in this period of uncertainty. We have had a little bit of education, facility tours, speaking engagements. We've had some students job shadow. We almost always have a student from Michigan State who can choose to rotate with us for 2 to 4 weeks and observe autopsies in court and that sort of thing. I think that's probably it. Are there any questions?
All right, thank you, Dr. Cole. Commissioners, Commissioner Bujak.
Thank you, Chair Burrow. Appreciate your many years of service and the opportunity to come to the medical examiner's office with several other commissioners to firsthand see what you do there and also the need for improvements to that particular operation. And I hope that moving forward we do find a better suitable location for that operation to continue. But again, thank you for your many years of service and appreciate all you do.
Hopefully we'll be able to continue.
All right, any other commissioners? Commissioner Hennessy.
Thank you. I appreciate all the reports I've heard over the many years, and, you know, that your list of significant accomplishments continues to increase, and that, and that you've continued to, work with us and to help expand the value of the service provided through forensic pathology. I am curious, with the 371 declined cases, do you ever have disputes over why you declined a case?
Okay, so the question is, if the declines, does anybody ever, are they ever unhappy, I guess, with the fact that we declined them? It's not very frequent. Well, oftentimes our investigator, when called with such a case, they're 88 years old, they had cancer, they died at home under hospice. Sometimes, some of the cases, it's because, well, a couple of days ago, they got up and went to the bathroom and fell. Okay, did you do an X-ray, to see if there was any injury? Well, no, they were on hospice. So it's this circular, and then our response generally is, well, if you didn't prove an injury, then there wasn't an injury, and they had adequate, other disease to explain the death. But as far as getting pushback, it's not very common. Usually where we get pushback, two areas. One is the family wanted an autopsy, and we didn't deem it necessary. And again, that's the criteria for when we do an autopsy is something, if anybody wants, I can expand on. Or occasionally, they didn't want an autopsy, and we ordered it. And under Michigan law, if the medical examiner orders an autopsy, the family certainly can discuss it, and they may influence our decision on occasion. But if we really think one has to be done, we do it. So those are the two areas where we get pushback more than a hospice or a terminal person dying expectedly that they report to us anyhow.
To ask another question, talking about the training programs at Michigan State, and I understand too, there's forensic pathology training at U of M, but are we seeing more people enter this as a profession?
Well, I don't know the exact numbers, but basically the year-to-year result is that there aren't nearly enough people that want to do it, that specifically forensic pathology. And one of the reasons, is that these days, unfortunately, such as my former colleagues, pathologists hate autopsies. They hate them because they take a while, they don't pay as well as doing other things, and they don't do many anymore because doctors in hospitals aren't getting many autopsies on their patients, and there just is generally, even though I think, not that I'm biased or anything, but that autopsies are a huge benefit to medical education and to feedback to practicing doctors. Did they miss something? Or maybe they didn't miss anything, either way. But nobody wants to hear it, so at least not enough people. So a lot of youngsters are not going into forensic pathology, and so that's why I guess Michigan State has put out ads to hire replacements, really, for me and for Dr. Start, though I might work part-time if it works out. But really, my full-time position needs to be replaced. And I don't know exactly, they haven't kept me up to speed exactly. I know there's been a couple of people with some interest, but as far as interviewing them and going more in depth to see if they really might want to be hired, I don't know. So I'm not sure what they're going to do come this fall.
That's interesting. I really appreciate that you're at least willing to continue part-time for the continuity's sake, and so that you can finally perhaps see this new facility.
Well, I'm hoping to. I don't. I know the intent is for it to be built, and so I hope it. But it's been a long time, starting in 2008, that the first significant attempt in building a new morgue began, and then that failed because of the economic collapse. So
Yeah.
we'll see what happens.
Thank you.
Commissioner Steck.
Thank you, Chair Burrow.
So good morning. Thank you for your report, Dr. Cole. Like Commissioner Hennessy, I've been sitting here listening to a lot of your reports over the years, and have, notwithstanding the subject, always enjoyed the report. As a follow-up to one of her questions, I understand, though, that if a family requests an autopsy, you've concluded that the situation doesn't qualify for one. They can always go ahead and get their own autopsy at their expense, can they not?
Yes, I guess everybody understood that. So, yeah, if they want an autopsy, and we just don't, well, obviously, as I've made it clear, I think, we just don't have the resources to autopsy everybody. In an ideal situation, everybody who died unexpectedly, or at least semi-unexpectedly, would get an autopsy. Then there's no, or at least fewer questions about what happened, but we can't do it. So if they do want an autopsy, and this happens 5 or 6 times a year, we have a list of pathologists, including WMed, the relatively new med school down in Kalamazoo. They have a forensic pathology department, and they sometimes will accept what we call private autopsies with the family. They do have to pay, the family does,
Right.
but at least they can get one. And then there's a pathologist over in the Detroit area that's done some. So, yeah, that's what we do. We refer them, and there have been a few times when, we have borderline cases. Does it need an autopsy or does it not? With our resources and everything, I tend to, these days, think, well, maybe, unless it's a homicide or something, we won't do it. But the family really wants it, and they can kind of make a case, or I can understand, they want to know if there's any inherited diseases or whatever. Something happened to them and it was never followed up on, like a diagnostic procedure, and they died. So I'll occasionally do them, but it kind of goes against my grain to let them go if the family wants an autopsy, but we just can't do it. And then we do provide names of other entities that can hopefully do the autopsy. So.
And I've had conversations with constituents who have had some questions.
Yeah.
Are the criterion that you use to determine whether an autopsy should be performed, are those criterion Dr. Cole criterion, or are these fairly standard criterion applied across the country?
Well, that's a good question. So is it my guidelines that we use, or is there sort of a national consensus? And the answer is yes, it's a little of both. Like in Michigan, our state medical examiner law does not mandate an autopsy under any circumstances. It doesn't mandate it. So, and it used to be, there'd be infants found dead at home of whatever, abuse or infection or something, and some of the smaller counties, their medical examiners would not order an autopsy. So that was, really pretty bad. So the standard, or what most people do if it's an infant, unless it was an infant with a known terminally ill condition, but anything other, previously infant found dead, we'll autopsy them. The other ones, the other cases, we just go with we start with what's the law in Michigan. Did the death occur as a result of an accident or a suicide or homicide? And with the accidents, we don't autopsy all accidental deaths. And nobody in the country does, as far as I know, all of them, because some people live a few days in the hospital or even a few hours, and they do scans and x-rays and so on, other procedures, where they can pretty well elucidate what the injuries are, and it fits. And we also generally talk with law enforcement, do you need an autopsy in this case? And sometimes they definitely do. Most of the time, if we don't think they need one, they're good with it. So, but to answer your question specifically, ultimately, it boils down to our office or me, whether or not to order an autopsy, and I try to look at, again, what's the history of the event, what's their medical history, and what's to be gained from doing an autopsy. Will it help the family, or will it help society? And so that's kind of the criteria. But it is subjective. Some people will do autopsies on a case where I wouldn't, or I'll vice versa. I'll do an autopsy where many people would not.
So, and I understand there is a degree of subjectivity to it, but is it your belief that you are and your department are providing autopsies within the standard that would be applied across the country?
Yes,
So
that-
it's not like we just failed to give you any dollars, so therefore a lot of people aren't getting autopsies they should. We're meeting expected standards.
I think the county has done, over the years, has done pretty well. Now, we do have a budget, or at least, maybe even that's too strong of a word, maybe, but they'll say, well, you know, they want us to keep it down, the budget as low as possible, so they'll have an
We would
idea.
never say that.
Within reason, but honestly, though, my response is always, yeah, sure, fine, if you want me to, cut $10,000 off this year's budget from last, if we run out of money for paying for autopsies in December, we are gonna do the autopsy. And the county will say, yeah, we understand. I say the county, it's the finance committee mainly, and
But I think that message needs to be clear, that we're not just declining to give autopsies because there's not enough money
No,
around.
we still have, resources, and we can't just willy-nilly do autopsies on everyone, including some people who may not really need one. But the county, to, I guess, address your issue, or the question, has never said, if there's an autopsy you, meaning me or my office, that we need to do, we're not gonna fund it. They've never said that. Contrary-wise, they'll say, well, we hope you don't go over budget, and some years we have, but they pay. So,
I'm sure in the past years, I recall approving additional budgetary allocations because you've had to perform more autopsies than you
Correct.
anticipated.
I would say the last few years, we've probably done some fewer autopsies, and some cases that maybe I would have when in past years, but I can kind of look at it with increased diagnostic capabilities of the hospitals and so on, that we go ahead and will not do. I will say very quickly, I've had dialogues with the trauma service at Butterworth, and because there are occasions when they'll have a traumatic death, even though they may have identified with their scans and so on some fatal injuries, they have a specific question about something that was not answered by a scan, and we have a mechanism now, and so instead of just saying, nope, you're out of luck, no autopsy, where I will talk with the surgeon, and if he or she can justify, and like I just said, hey, we don't know what was going on in the abdomen. We didn't have a chance to do all of the precise scans that we'd like to do. And I'll say, we'll do it, because I want them to learn as much as they can and make them better surgeons. So there are, and occasionally with families, it's been similar, where if they can present a reason to do an autopsy, especially if it'll affect their health or their family members' health, then we'll do it.
No, thank you for that. And I think that this board and our public want to know that we provide the service when it's appropriate, not just because we have the dollars.
That's the answer, and coupled with the fact, however, we don't have unlimited resources, and we have to make decisions sometimes that are difficult.
Fair enough. So just a quick follow-up. I saw the reports on the deaths, the drug-related deaths. You didn't do a trend report. We hear a lot of stuff that drug deaths are trending down. Is that observable in your work?
Well, yeah, the best way to look for trends like that would be year to year, and we have some data on the 2025 year, last year. I don't know if you have a particular question. I could look. Brittany thoughtfully brought along some data from, because we're still compiling the final statistics. I have not completed all my autopsies that I did in 2025 for the reasons we've discussed. But anyway, so we can look year to year. And fentanyl, I think, did go down last year. There's been interdiction attempts by the government, and particularly the DEA, and I think we have less fentanyl than we did, and particularly less fentanyl overdoses.
Well, I don't want to take away from your important work, but if you do have the data, I would be interested in seeing what trend data you have on drug-related and suicide deaths.
We'll work on that and get something, and we got Jenny over there to keep an eye on us.
All right, and thank you for hanging in there. I think the very first report I heard from you was, I'm on the edge of retiring, we need to stabilize this department. I think we're 11 years later.
I probably should have been gone years ago, but.
Well, I think I made a commitment at some point, I'm going to read your book before you retire, so hang in there for a little bit longer, okay?
Okay, it won't take you long to read it.
Thank you.
All right, well, thank you guys for having me.
All right. Great, thank you very much. All right, next item on our agenda, this is an action request brought to us by the Sheriff's Office, the Michigan Indigent Defense Commission, grant position request. And this is recommend to the Board of Commissioners to add 2 full-time positions under the Michigan Indigent Defense Commission grant at a cost of $234,285. This is an action request. The summary of the request is in your packet. So can I have a motion and support, please? Motion by Bujak, supported by LeGrand. Commissioners, comments, questions, or concerns? Commissioner Steck.
Thank you, Chair Burrow. Just to confirm, this is already in the budget, is it not?
Yes, in the MIDC budget and the Kent County budget.
So this comes out of our grant entirely, and we've already approved it through the budget process. Thank you.
Commissioner LeGrand.
Thank you, Chair. I just had a couple questions from reading the details in the packet. And I'm wondering, it said that there was a volunteer officer who was, is that continuing? Is that being replaced? Is that what's going on?
Yeah, those have been repositioned back into our general staffing matrix now that we're able to proceed with a grant-funded position.
Okay, that's what that meant. Okay, I see, got you. And then I did have a question when you were talking about all of these visits have to be supervised, some of them are quite long. Does that, is there, are they in the room with the person? Are there any privacy concerns?
The privacy concerns aren't there. I mean, we've added some boosts and some privacy for the client privileged conversations. We're not concerned with that. It's just the additional movements of inmate making them available for those professional visits.
Okay, and these are all within the jail facility, the correctional
Correct.
facility,
Yep.
right? No one, we're not talking about any transportation elsewhere.
Correct, right. That's the
Okay.
advantage that we've had since, we mentioned the COVID-19, but it's the video that's really changed how we do things, so.
Okay, great. And have you hired new people for this, or people just moving around
We're
within
moving
the-
people around. They're
Yeah.
becoming comfortable with technology. It's very easy to use, and defense attorneys love it. I mean, they're saving themselves a hassle from coming in, and it prevents, contraband from coming into our facility as well, too, so we like it as well.
Okay, great. Thank you very much.
Great. Any other commissioners? Commissioner Faber.
It's just a process question. We have a board member, I believe, of MIDC, aren't you?
Correct.
All right. So can you just, I wasn't here when sort of the big decision was made around the Public Defender's Office. Does the Public Defender's Office make the grant request annually, or does the county make the request? And what is the sort of timing on that? Because in the packet, the grant period is already from October 2025 through 26. We're kind of halfway through that. Just kind of, can you help me think through the
Sure.
timeline and process?
Right, so in the spring, the MIDC will start receiving grant requests from all of the individual public defender offices. And there are some counties, especially the very small ones around the state, which is a lot of them. They use the roster system that we run through the administrative office. But in cases like Kent, where we have a public defender's office, they put together the grant request and submit it. And the MADC has a meeting in early summer where they look at a huge number of these things. But what I found is sometimes they delay them just because that's tonight. Sometimes they'll delay them because of things they want flushed out in a particular request. But I think we approved the last ones in before December, early December.
All right, any other commissioners? Again, this is an action request. We will see this at full board on the 12th of February. Everyone in favor, please say yes. Yes. All those opposed? That has been approved. Next item on our agenda is the opioid settlement. This is recommended the Board of Commissioners to add one full-time public health educator position for prevention education expansion in schools, included in the opioid settlement spending plan approved by the Board of Commissioners through Resolution 7/18/2486, with funding approved through Resolution 8/28/2556. Again, this is an action request, going to go to full board on February the 12th, and the summary of request was in our packet. Can I have a motion and support, please? So moved by LeGrand, supported by Steck. Commissioners. Commissioner Faber.
I was hoping we could get a little description of the Bothell Life Skills Program. I see some folks here from the Health Department, probably ready for me to ask that question. And when we're talking about moving from 2,386 youth educated to 3,286, can you describe a little bit what that population is, and what percentage in general of sort of the demographics that the program is trying to serve, what percentage of those are being served through this program?
Sure, thank you. Good morning, Commissioners. The Bothell Life Skills is really the only large program that has proven results for reducing risk for substance use that is published. It's an evidence-based program. We've been using it at the Kent County Health Department in local schools for many, many years. I've been there 18 years, and it was in existence before I came. Recently, I went to a national conference when I knew we would receive the opioid settlement money, and I went to all these different colleagues from all over around the country and said, what are you doing for prevention education? Without exception, everyone said Bothell Life Skills. So it is very well received by our schools. It is a curriculum that can be customized for the needs of the school, but generally we focus on middle school and early high school. And it is very focused on prevention. It is not perfect for people who've already been involved with substances, but it's really trying to get accurate education to students, not only regarding the dangers of using substances, but also for things like communication skills, standing up to peer pressure, social media, all of the things, and they even do role plays of how do you handle situations when someone is offering you a substance? What do you say? How do you get out of those situations? So it's a very well-established curriculum, and we have some talented, creative, fun, young educators that go into the middle schools, and a little bit in elementary schools as well, 4th and 5th grade, and a little bit in high schools. But they present this material usually in a science class or a health class. The school teacher remains in the classroom while our educators go in. We don't charge the schools. Typically, it depends how long their classroom, because it's by minutes, but typically it's 12 to 14 weeks of classrooms, 1 day a week, and they do a pre-test and a post-test. And what they're really evaluating, because it's the easiest thing to evaluate for, is perception of risk. So what is the student's perception of risk before they took the class, and what is the student's perception of risk when they're done with the class? And then, based on the perception of risk, we extrapolate a little bit, believing that that is going to guide their decision-making.
So just sort of the second part of the question, do we have an idea of like what percentage of those middle school, high school students are being communicated with versus the total population of that? Like,
Yeah.
Are we scratching the surface here, or are we like really able to get this in front of as many kids as possible?
Yeah, we are scratching the surface. Yeah, and we are turning away opportunities all the time, where schools are saying, can you come in for 3 more sessions? And we have to say, well, we're booked in other schools, we can't. We probably are, and this is guess off the top of my head, but we're probably touching about 15 to 20% of the students that we could be touching. So we try to go into classrooms that are a bit larger, so 18 to 24 students, and we go to schools that we believe have the highest risk. If they were already doing the work with a different program or using their own model, we probably would go to a school that has less to offer.
Great. Commissioner Steck.
Thank you, Chair Burrow. Good morning.
Good morning.
I'm glad to hear that we have young, energetic, and fun presenters. I'm sure we have some more senior, fun people too, right?
As someone that's about to retire, I want you to know, seniors are fun too.
We're all fun. So we just heard from Dr. Cole that, at least within his statistical world, there were 0 deaths, opioid deaths, among his minor population where he's performed. I'm sure that doesn't mean that there have been no deaths, and I know that there have been. But what metrics can you use or do you use other than what sounds like more of a subjective perception of impact, which sounds valid, but are there other objective metrics that you use to sort of test the effectiveness of the program?
There are other metrics that we in Kent County do to test the metrics, because once a student is out of our classroom, we don't have a way to find out 5 years later or 10 years later if in fact they developed a substance use disorder. However, the program itself does do that. So Botvin's Life Skills does a lifespan evaluation. Those students who have successfully gone through the Botvin Life Skills program do have lower incidence of substance use 5 years, 10 years, and later. So when we maintain fidelity to the model, we trust those longer-term metrics to know that this is a successful program.
And these are metrics that have borne out because the program's used across the country.
Across the country and over time.
Yeah, all right, good, thank you.
All right. Any other commissioners? Commissioner LeGrand.
Thank you, Chair. I just want to express my gratitude for the Health Department for prioritizing this. I really think it's great, wonderful that you can look at numbers and see that it's making a difference. I'm wondering, is this the kind of program where you bring in people who might have been personally affected? You know, the way drunk drivers might go talk to young drivers who, does anything like that happen?
In the Botvin Life Skills program, we do not.
Okay.
It's logistically, it's a little hard to get our own people into the schools, let alone bring in guests from the outside. In fact, every now and then, I go in and observe a class, and I have to, bring ID and fingerprints and all kinds of stuff just to be allowed to go in and sit in a class. So that's really not a possibility. However, we do have videos, and we show videos with testimonies of people who said, and one of them that seems to be quite effective is parents saying how grieved they were by the loss of a child from substance use. And these young people are seeing, a figure similar to their mother who's grieving because of the loss of a child.
Oh, well, that's very powerful. Well, I'm very glad that we're able to, I know a lot of us are frustrated with the state of the lawsuits and maybe, not a big enough payback for all the damage that was done, but I'm really glad to see it in this sort of prevention space. It's great. Thank you.
Commissioner Hennessy.
Thank you. Since you brought up your retirement, your pending retirement, I just want to thank you for explanations like you're giving us today. They're very clear, they're very informed, they're very factual, and I've appreciated that over the years, and we'll miss you in the future. I know that I'll have more opportunities to see you before that date comes, but it's soon.
Yeah, thank you very much.
Commissioner Steck.
Just for a second, I assume you're using the Dr. Cole approach to retirement?
There's no answer to that one. So, no. Any other commissioner? All right, seeing no one, all those in favor, please say yes. Yes. All those opposed, that will be moved to full board on the 12th of February. Our next item on our agenda is the Materials Management Planning Committee appointment. This was a appointment that Commissioner Steck, Commissioner Pakla, both sit on the DPW with me, and I thought that was an appropriate use of having the three of us meet with this individual. And this Jamie Rye, very well qualified, great resume, and very passionate, and he'll serve this committee very well. So I do need a motion and support, please. Motion by DeBoer, supported by Steck. Any comments or questions? All right, all those in favor, please say yes. Yes. All those opposed? Jamie will go to full board on the 12th. Next item is commissioner comments. Any commissioner comments? All right, so that being said, so I got a couple reports or a couple things I want to talk about. In our packet, we do have the meeting schedule and all the groups that have to come present to us. If you can see, I think those of you that know me well, I don't necessarily love long meetings, but I don't like too many meetings. So I will try to do our best to have one meeting a month. And that being the case, you'll see that we've got a lot of 2 presentations at a time, several different occasions. So again, I'd rather have an hour-and-a-half meeting once a month than 2 45s. I think it's a respect of your time, staff's time, and it makes every one of us more productive. However, we do have a lot of work to do, and I won't be canceling them if we have the work to do. If there is something that absolutely has to be approved before a board meeting, we could always come in here at 8 o'clock, quick, do one action request if that was the case. So again, I am going to try to respect your time on that. So look at that. I thought that would, Taylor got this out for me. I thought it was very important that all the commissioners here saw the groups we had to see so you know what's going on. Another thing, we did, under contract, or working with contracts right now with Midwest, our new lobbying firm. So that being said, I didn't have anything put out for any legislative priorities at this point in time. But we are going to have an email that Taylor will send out just asking commissioners if there are any legislative priorities that they would like to see. Please keep in mind that it's a bipartisan or a split House and Senate at the state. So if there's something that is going to be very one-sided, it's really not a priority that I'm really interested in moving forward or that will even pass. So a couple items, talked to Commissioner Faber after our exec meeting the other day. One, the clerk came up with new voting machines that they're going to be lobbying the state, probably something that we should have as a priority, along with waste to energy closure. My understanding, talking to Commissioner Pakla and Commissioner Faber on that there could and would appear to be bipartisan support to make some adjustments to that. So again, looking for things that we can get done this calendar year on those priorities. So look for that email, and you'll see that very shortly on that. Any commissioners' questions? Commissioner Hennessy.
This is the first that I've officially heard about the employment of Midwest Strategies. And I'm wondering if you could just sort of review a little bit about how, I know that there was a committee that worked on this, and a little bit about how this decision was made. And when
Well,
it
maybe I
begins.
wasn't supposed to say
a little
anything.
bit
I don't
more-
know.
Brought it up.
Oh, it has been awarded. All right, good. Al, if you
Yeah,
take that, that'll be
we're
good.
negotiating a contract at this time. Yeah, we had basically, if you look at the decision-making model, purchasing can actually make the decision because of the size of the contract. But knowing that this was one of more interest, obviously, to everybody who sits around this table, we put together a group of 3 staff and 3 commissioners and our purchasing rep that did review all applications, interviewed 3 finalists, and ultimately decided to go with Midwest Strategies. So there'll be more information. I wasn't planning to discuss that today quite yet, but we'll have more information out this week.
You're welcome.
That isn't a decision to be made by the board, then it's
No.
made through purchasing and then.
Correct.
Process.
Yes.
As a bid, does it come to us?
No.
Okay.
All right. Any other comments or questions? Again, we'll work on those priorities, and once we have the new lobbying firm in place, I think there could be some good work that could be done here with the board. All right, if there's no other questions, meeting is adjourned.